So, Dr. Chris, let's pick up to where you did the financial driver evaluation with the attorney. So we did the educational sales presentation. They obviously became aware of a lot of information that was potentially missed, right?
Yes.
Okay, so we go over into a financial driver evaluation, which means we look at one of their cases and we use a checklist to see what information was not documented. Now, just roughly, when you did that on this one particular case, what percentage of information was not even documented that should have been?
I would say about roughly 50 to 60% wasn't documented.
Okay, so then you have him refer the patient over to you to document the material that was not documented, right?
Yes.
Okay, so let's walk through some of the main categories and let's do a comparison contrast to see what was missing and how significant was it. All right.
Okay.
Okay, so we'll stick. Obviously, the mechanism of injury was the same. How about injury magnifiers? Did you find any injury magnifiers that the other doctor did not document?
Yeah. There were about four injury magnifiers that I found that the doctor didn't have.
Okay, and then did the patient have subjective findings at MMI?
Yes, she did.
Were they primary? Was there at least one primary finding directly related to the mechanism of injury?
Yes, it was.
Okay. So hybrid findings. Let's go into some of the categories. Let's go into muscle weakness. Did you have any trouble with find any muscle weakness?
No muscle weakness.
Okay. Let's go into the three ranges of motion. Was your active range of motion different from what theirs was?
Yes, their active range of motion was full at the time of their final re-exam, but what I found out was that the patient was actually on medication. They were on over-the-counter medication at the time, which altered their results.
What kind of
So,
medication?
she was on Tylenol and ibuprofen. She was taking it
Well,
regularly.
I think that's safe to say that those are absolutely designed to decrease pain and increase mobility, right?
Right.
Okay, so that's an important finding, right?
Yes, it is.
Okay. Overpressure range of motion. Did you have any positive overpressure range of motion?
Yes, we had positive overpressure range of motion in the neck and in the back.
Was it in the plane of the mechanism of injury?
Yes,
O-
she was hit from the
Okay.
driver's side,
Driver's
and so
side. Okay.
we had to
And they did not have that documented.
they did not have any
Okay.
did not do any overpressure range of motion.
So they didn't even do it. Okay. And then let's hold off on the x-ray findings for just a second and go into, so that's muscle, range of motion, probably no neurologicals, dermatomes, reflexes, cranial nerves, nothing there, right?
Nothing there. Correct.
Okay. Did they even do them? Did they even do dermatomes or reflexes or cranial nerves?
They did cranial nerves, they did some neural, they did some muscle as well.
Okay. And then from there we go into the orthopedic tests. Did they have any primary positive findings with
Yes, they
the
did.
ortho? Okay. At MMI they did?
At MMI, they did not.
They didn't do them or they didn't have them?
So they didn't have on her final re-exam, the patient final re-exam, which was one day into the third phase of healing. They had negative, all range of motion was, there was complete range of motion, and then there was all negative orthopedic tests.
And then when you did the orthopedic test, what did you find?
I found positive orthopedic tests in the neck and in the back.
That directly related to that mechanism of injury?
Yes,
And you said they cut her off at MMI right at the beginning of the remodel phase?
that's correct.
So they didn't even do two re-exams within the remodel phase to see if there was any improvement.
That's right. They did not do that.
That they probably did not even mention the 3 phases of healing in their report, did they?
They did not mention the 3 phases of healing.
Yeah, I was going to say there's no way they would have, because that would have made them look bad. So, okay. So now, obviously, by the time you did the evaluation, the patient was definitely in or past the remodel phase of healing.
That's at the point that I did the examination, she was in the halfway through the remodel phase of healing.
Okay. All right. So that takes care of that. How about palpation? When we go to palpation, did they do any palpation?
They did do some palpation. Yes.
And was there a difference? Did they have anything versus what you had on when you checked them?
Yeah, they were at their final re-exam. There was no positive findings with palpation. However, with mine, I definitely found some related to the mechanism of injury.
How about fixation?
Yes, had fixation in the patient's neck and back.
What about tenderness?
Yes, there was tenderness as well
Muscle spasm?
and muscle spasms.
Guarding? Okay. I take it they did not do a dynaram or a test.
Correct. They did not do a Donaram test.
Did you happen to do a dynaram test?
No, I did. I did not have.
Okay. Do you know of somebody locally that does have a dynaram?
I'm still looking for somebody locally that has Donaram.
Okay, yeah, because see how that would be an important test with this case right now. Can you see that?
Yeah, yeah, it would be. It would be
Yeah,
huge.
especially with the next finding we're going to talk about. So that's palpation. Then let's go into they didn't do any blood tests, right?
Correct. They did not do any blood tests.
Okay, and did you order any inflammatory indexes?
No, I did not.
Okay. And have you ever ordered a blood test before?
I have not ordered a blood test before. I've called and inquired about it to get ready for it, but I haven't ordered any before.
Okay. And then let's go into the x-rays. They gave a diagnosis of what? Cervical sprain strain?
Who are you talking about? You talking about
The initial doctor, chiropractor?
the chiropractor actually did not take x-rays.
Didn't take any x-rays at all.
Take any x-rays.
Wow. Who else did the patient go to?
The patient went to the hospital initially, and they did take some x-rays.
Okay. Of course, you already know when they take x-rays, they're typically static, non-weight bearing, or they don't take dynamic motion pictures, or there could be guarding. So in the initial x-rays, did they find anything?
They found some degeneration of the spine, but that was it.
Okay. So you took a look at the x-rays, and then what'd you find?
I found that the patient had rotational malposition, going to the left and to the right, which falls in the line with the mechanism of injury.
In the low back or neck?
In I found it in the low back, but
In the
I got something to tell you.
in the low
I,
back. Well,
yeah.
that's curious. So did they do a left and right lateral bending picture?
You talking about the chiropractor, or are you talking about me?
The x-ray that you saw the rotational malposition on, what film was that?
That was on left and right lateral bending.
Who took those pictures?
I sent them. My X-ray machine was down, so I sent them down the street.
Okay. The reason I'm
exactly.
asking, okay, the reason I'm asking is, that is not a normal x-ray for an emergency room.
Correct.
They don't do motion studies.
Yeah, in my experience.
Yeah. Okay. So when you said that, I'm like, wait a minute. There's emergency rooms don't do that. So you evaluated for the ligamentous integrity in the neck and the low back by doing motion studies, right?
Yes.
And then what'd you find?
So I found rotational malposition throughout the lumbar spine, with left lateral bending and right lateral bending. when I sent the when I sent the images off to Dr. Pedley, she actually found the same thing in the neck. C3 through C3 to C7. She found rotational malposition bending to the left and the right.
Okay. Yeah, and that directly is associated with being T-boned.
Correct.
Yeah. Okay. Which is but so there you found rotational malposition, but you did not find any translation or angulation?
So Dr. Pedley found translation in the neck.
Okay. The reason I ask is it's pretty unusual to have that trauma, find the rotational malposition, and not have some form of translation or angulation because it works as a motor unit. So
Correct.
that's why I asked that. Okay, so she did find some translation issues in the neck?
Yes.
Okay. Same segment as the rotational malposition?
Yes.
Okay, see how all that correlates now?
Yeah, and I wanted to ask you about that because of the fact, I guess, how can I relate that though through to the mechanism of injury, given the fact that it
What's
was
definitely related to the mechanism of injury.
okay.
Yeah, when you're T-boned, that's when you're most likely to have rotational malposition. And remember, anytime you have any type of ligament damage, because it's a motor unit, it all works together. That's why it's real rare to see rotational malposition without having any translation or hyperflexion extension injury associated with the same motor unit. That's rare. Usually, if you find rotation, you find them together usually.
Yeah, and I understood the rotational malposition, thinking about the mechanism injury.
Yeah.
But I just wasn't sure about the translation aspect, because I was thinking more so of a rear end collision or front impact collision.
No, I mean, it all works together. The anatomy all works together. That's why they call it a motor unit. So, okay. So all of that corresponds. Did she measure it, or did you get any measurements with the translation or?
Yes, I did. Let me pull them up real quick for you. Because I want to say she measured it at 1.8 millimeters. But let me pull it up real quick.
Okay. Which sounds about right. That sounds about right. So, to take a percentage of that, over 1 millimeter is pathological.
Right.
Okay. So it's altered intersegmental spinal motion. It's not
Right.
ALMSI.
Right.
And so that's what you would call it, pathologically altered intersegmental spinal motion. And then you'd have pathological cervical rotational malposition. And then you've got 1.8. So you would take a percentage of that. So it'd be a lower percentage. So out of 25% impairment, 0.8 would be a much lower percent. So did you do the calculation yet?
Yeah, so originally I did the calculation just when I looked at the x-rays with the rotational malposition. And that's why I'm glad we're discussing it, because I didn't know exactly how to factor in, once you found that translation malposition, how to factor that in.
Well, remember, as soon as you go to the table, it's region. Remember that?
Right.
And you can't add in it. In other words, when you give an impairment for a region, even though there might be 4 or 5 different motor units affected, you can't do that because the impairment's given as a region.
Right.
Okay. Now, the only thing you could do, remember, is if you had an abnormal lordosis, pathological lordosis, or physiological line of stress, you could add 1% per component based on the range of motion table. Remember that?
Right, which the patient does have.
Both are one.
has the abnormal lordosis.
Okay. So one. So, okay, you would take the percentage of 0.8 relative to 1 to 3.5, that percentage of the 25% impairment, and then you would add the 1% for the lordosis.
Oh, okay.
It's not combined. It says it right there in the table. So it is to be added, not combined.
Added, not combined.
It
Okay.
says it in the table, in the ROM table. I mean, it flat out says it's an add-on. It literally says if you have a structural issue with signs and symptoms, it's an add-on of 1%, not combined.
So, Doc, you're looking at the range of motion table, correct, as opposed to just the DRE table.
I'm looking at both.
Okay.
I'm starting with the DRE.
Okay.
I'm getting I'm getting a percentage of the impairment for the 1.8. That's going to be a lower number. And then
Okay.
I'm going to add one whole person impairment rating to that number for the abnormal physiological line of stress. And so I'm going to include both tables. So it'll be page X, table X. It's this percentage, 0.8 is this percentage of 3.5. And so we take that percentage of 25% impairment rating. That's how you got that. Then we're going to go to the abnormal cervical lordosis and go over to the table for range of motion. It's right there. And then we'll just add that table in where it says add 1%. So then you just add them both in, and now that's your total impairment rating.
So, Doc, when you're saying you're taking the percentage of, you're looking at the whole the impairment based on, um, I guess I'm trying to just get it all together. You're basically taking the 25%, you're cutting it in half because of the fact that the patient doesn't have, um,
Well, it's not half, it's going to be less than half.
less than half.
Say, well, 1 to 3.5 is your number, right?
Right.
Okay. So if you took a half of that, that'd be 2. If you subtracted one from the other, is 2.5. 2.5 divided by 2 is 1.25. So see, if it was there's 2.5 is the difference between.
Right.
So half of that would be 2. What is that? Half of 1 to 3.5, 2.5 would be 3, so 2.75 roughly.
You're saying half of 2.5, Doc?
Well, I'm going to the halfway mark first.
Okay.
So that would be halfway mark would be about 2.5, right?
Right.
So if it was 2.5, we would just give 50% of the 25% impairment rating. But you're
Okay.
not at 2.5, you're at 1.8.
Right.
So instead of 12, like 12 to 13 would be 50%. So you're going to be down. I mean, it's going to be a lower number. You're going to be around, 4 or 5, maybe something like that. It's going to be a lower number.
Oh, okay. Now I see
Yeah.
how you're getting there.
Yeah. Because it's only 0.8 off of normal.
Okay. Right.
So it's not even 25% of off normal.
Right.
So it'd be even less than 25% of the 25% whole person impairment rating.
Right.
So, Doc,
So
question: the 3.5 is the mark, yet he's got 1.8. So, do you use 1.8 and divide it into 3.5 to find out what percentage of the 3.5?
well, if
You're using 0.8, but you're saying pathological happens at above 1, and I understand that. but yet the guides is using 3.5. They're including that 1% that's there already. That's not pathological, right?
Yeah, and we don't want to include that.
Well, wouldn't we want to include it so it's apples to apples? We're comparing their chart to what we are. In other words, we want to add 1.8.
Well, I'm going to start from the point of pathology. I'm not going to start from, so whatever percentage the pathology is of the 25% number, and that is 3.5, that's the percentage I'm going to take of 25%. I'm not going to start at 0, because 0 to 1 is normal.
But aren't they using in the AMA guides 0 to 1 as part of their calculation to get to 3.5?
That's true. I'm just telling you what I'm going to do in front of a jury that makes sense.
Okay.
So I'm looking at the pathological portion. That's all I'm doing. The pathological. So what's the pathological number? It's between
0.8.
It's between 1 and 3.5.
Right.
So it's 0.8. So the pure pathological number would be 2.5.
Okay.
And you're at 0.8. So what percentage is 0.8 of 2.5?
Doc, I got 32%.
Well, 3 times 8 is 2.4. Yeah. So that sounds about right.
So with the 32%, how do you?
It'd be 32% of 25%. 20, because 25% is the 3.5.
Okay.
So 32% of 25.
It's 8.
Yeah, 8%.
Now, the only caveat to that, remember, it's a range of 25 to what, 28, right?
Right.
And remember what makes it 25 versus 28? What's the
other factors, injury magnifiers, ADL?
No. ADLs. The quantity and quality of ADLs determine whether it's a higher or lower number. So it gives you a range of 25 to 28. So why don't you pick 25 versus 28 versus 25, or 27 versus 25? You see?
Right.
It's the quantity and quality of ADLs. Now, does it give you a specific number? No, it's totally your opinion. So you have to look at the ADLs and go, how many ADLs were involved and how severe were they involved? And it's a total judgment call on your behalf. So remember, you just have to be able to explain it to an 8th grade educated juror, and it makes sense. So if they don't have very many ADLs and they're not that severe, I'm saying 25.
Right.
If they have quite a few, and what's the difference of quite a few or not many? Well, that's your opinion. That's why they're called guides, not rules. So if they had several ADLs and they were severe, remember, I'm going to evaluate the ADLs on the functional capacity index, 0, 1, 2, and 3. So if I have several ADLs and I see several 2s or even some 3s, I'm going with the higher number. But if I only see a few ADLs and they're in the 1s and maybe some in the 2s, I'm going to stick with the lower number. And that's how I'm going to justify it makes sense. Okay. Because I want credibility when I do this.
Right.
I don't want to pile on. So in this, how many were there, in your opinion, how many ADLs were affected when you did the impairment indexes? How many were affected? A little, average, or a lot?
A little.
Then, and when you did find them, they probably were a grade 1, mostly, right?
Correct.
Yeah, that's kind of common. That's kind of common for a low impact soft tissue spinal injury case. So I would say 25. And by the way, I'm putting this in my report, right? I'm going to say, I'm going to put this in my report because how much more authoritative does it sound when I add this into the report? And how much more credibility do I have when I say my option was to use either 25 or 28 and I picked 28? And this is why I picked 28. How much more credibility do I have now?
You have a lot more credibility. We can
Yeah.
explain that.
How many times you hear me say, don't be an impairment whore?
You said it often.
Okay. Because that's chiropractors are kind of known for that. How high can I get the impairment rate? I'm like, no, that's not the picture. The cumulative is the picture. It's not just an impairment rating. So in this case, then I would have stuck with would you come up with 32%?
Yes.
So I'd have took 32% of a 25% impairment rating.
Makes sense.
So what'd you get for that?
We got 8.
Okay. Then I'm going to add 1 for the pathological lordosis. And I'm going to reference it on the range of motion table. It's right there. It's in plain sight. I mean, it's right there.
Yep.
It says you can add if there's pain, and that's even without degenerative changes. After trauma, at MMI, if there's pain or structural dysfunction, you can add 1% to the region. And it says add, don't combine. So I'm going to go 8. That's how I got 8. So I would have said the impairment rating was at 8 based on 30. It was 32% pathological of the 25%. And I decided to use 25% impairment, not 28, because it's whether you pick a higher or lower number according to the AMA guides is based on the quantity and quality of ADLs that are affected. And so in my opinion, it would be 25. So from a 25% impairment, we would take 32%. That would be an 8% impairment rating. That's how I justified my 8% right there. Then I'm gonna add. Then also in the range of mode, there was pathological, those structural pathological changes with the cervical lordosis, say what they were. And then I'm going to cite the table, the range of motion table, and add that 1. So there's the 1%. And now I just go down and total them. So the total whole person impairment would be 9%. That's how you got to. Does that sound like you know what you're talking about now?
Yeah, Doc, it does.
Okay. That's how you do it. You think your attorney's going to appreciate that?
Yeah. They're gonna.
He's going to love somebody that knows actually how this works and can explain it to a jury. Okay, so there's your impairment rating. And by the way, I'd say that's about right for low impact soft tissue spinal injury.
Hey, Doc, before we go any further, do you also add in, or do you don't factor in the rotational malposition?
We're not. Why? Because it's the same motor unit. Okay. And if you're going to use the table says region, not motor units.
Okay.
That's why.
That makes sense.
Okay. Now I'm gonna cite them, right?
Okay. Right.
I'm gonna cite them, but when it gets to the impairment rating, we just covered how I would do the impairment rating.
Yep.
So if I said that in front of an 8th grade educated jury, how much sense would I look like I'm making?
A lot of sense.
And I've got credibility because I'm not slamming them with the highest of everything.
Yeah, you come out sounding very reasonable.
Right. That's how you should sound. Because remember, it's all the categories you want, not one magnified. Okay, so you got your impairment rating. Anything else you found?
We also have the rotational malposition in the lumbar spine.
Does she have symptoms in the lumbar spine?
Yes.
Okay. Then you're going to want to do the same thing for the lumbar spine.
But that was the only thing that was found that was relevant. So there wasn't any translation or angulation, anything like that.
Okay, that's fine. Did she have any tenderness on palpation,
Yes.
fixation?
Yes.
See, those correspond, right? Kemp's test.
Yes.
See, all of those correspond, don't they?
They do.
Okay. So yeah, so I'm gonna go ahead and I would have already cited all that information as I went through the categories, but in this case, I'm gonna go into the low back, and you said it's lateral flexion malposition. So again, I'm gonna look at the table and just scale down and go, okay, where do I want to start with this? And there you got three options. You got you've got the category 2 option in DRE. You got category 4 option. You can take a percentage of, or you can go over to the range of motion and use that. So which one would you prefer to use? I would probably just take a percentage of AOMSI. That's what I would do.
There was no AOMSI.
In the low back?
Right, it's just rotational malposition.
Right. But in the low back, there's such a thing called AOMSI. You know that, right?
Of course. Yes, sir.
Okay. So I'm going to do the same thing. I'm going to take a percentage. Okay. Because remember, in the low back, it varies more depending on if it's L5, L4, L3, L2, right?
Right.
L1, 2, and 3 are kind of the same. L3 and 4 is different than L5, right? With translation and okay. So what motor unit are you talking about?
So this is throughout the lumbar spine. This is rotational malposition going left and right from L1 to L5.
Okay. So if it's throughout, I'm just going to pick one region.
Okay.
Right. I'm not going to say 5 different motor units. I can't because the table says region, not motor units.
Right.
Okay. And then you would become an impairment whore, right?
Right.
All right. So we're looking for credibility. So I would go, what unit did you say it was?
It was L1 through L5.
Okay. So the greatest, what I would do is I would just pick the motor unit that gives the greatest percentage. Because remember, you got 3 different variations. 1, 2, and 3. Look at the table for AMSI in the lumbar spine. Okay.
Okay.
And it gives 3 variations because the curve is different in the low back than the neck, right? So
right.
the number for 1, 2, and 3 is the same. 3 and 4 is slightly different. And then I don't have it in front of me, but I think it's 15% 1, 2, and 3, 20% L4, and 25% L5. I think that's what it is.
That's right. That's right, Doc.
Okay. So I'm going to take the worst of the categories. So if they were all involved, I know I can't do them all because we're talking about the region. So I'm going to take the one that is the worst on a percentage basis, and that's the impairment rating I'm going to use.
Which in this case will be L5.
Yeah. Now the only difference is it's not a measurement. See, and we're not measuring translation and angulation.
Right.
But we're still talking about the same pathology, aren't we?
Yes.
Ligamentous integrity, motor unit ligamentous integrity. Okay. So I'm going to use their numbers for translation and angulation. And then I'm just going to look at my rotation. And then I'm just going to, instead of measuring it, because there's no direct measurement, what I'm going to do is use my opinion. This is, again, why it's called the guides, not the rules. So I'm going to look at the rotational malposition and go, well, I'm going to break it into 4 quadrants to make it easy. Is it more mild, moderate to severe, or severe? Mild, moderate, moderately severe, or severe? It's now, again, this is your opinion. You're just looking at it. So if it's not rotated very much at all, or hasn't rotated, I'm going to say mild. If it's rotated a little bit further, I'm going to say moderate. If it's gone halfway, it's pretty significant, I'm going to say moderate to severe. And if it's, significantly rotated, I'm going to say severe. So I'm going to use the 4 quadrants. Mild. Is it more mild looking, moderate looking, moderately severe looking, or is it severe? That's, by the way, those 4 quadrants are out of the AMA guides for quantification purposes. So if you were to look at that, what does it look like to you? Does it look more, when it's rotated, does it look more mild, moderate to severe, severe?
I would say moderate to severe.
So it's significant.
Yes.
Is that right? Okay. Well, then you would take 75% of that impairment rating. You see? Okay. If you pick mild, how much sense does it make to say to a jury? I'm going to say that's 25%. If it's moderate, I'm going to say that's 50. If it's moderate, you see how that works?
Right.
If it's moderate to severe, I'm going to say 75%. If it's severe, I'm going to give it 100% of its ALMSI. How much sense does that make?
That makes a lot of sense.
And then you have the same variable in the low back, don't you? It can be a low number or a high number, right?
Right.
And once again, that's based on the quantity and quantity of the ADLs. You said it was kind of low, so I would just stick with the lower number.
Okay.
Not the higher number. So I would take 75% of the lower number. See how that works?
You said 75% of the lower number
of ALMSI, the low number of ALMSI.
Okay.
I'm gonna take the 75 because of the severity. Now, everything that I'm telling you is in the report. I'm going to say that lesion, in my opinion, is moderately severe on a scale of mild, moderate to severe, severe. I'm going to say that. And because it's moderately severe, this is why I chose 75% of the total number, 25%. So it'd be 75% of 25% would be your impairment rating.
Okay. So in this case, since it's the low back and it's I believe it's
18.75.
It says 20 to 23%.
Use the lowest number, 20, because we got low ADLs, right?
Okay. Right.
So you would take 75% of 20%. That's your
15.
Okay. And then in the low back, remember, the secondary factor was lordosis or McNabb's line. Did you have any of those?
Yes. Let me go back up here.
That McNabb's line is, I say, you check that all the time because you'd be surprised how many times that's positive. So if
I don't see anything else. There's no loss of lordosis.
Okay, so let's say if you did, then we would come over, because that would be a secondary finding, right?
Right.
Then we'd come over to the range of motion table, and that tells us we can add 1% per region for a structural anomaly. You see how that works?
Yes.
Okay, but we don't have a structural anomaly. So we do not have McNabb's line. We do not have lumbar lordosis. So we're going to leave that alone. So you've got the low back, I would call 25% of, you said the low number was 20?
Yeah, low number is 20. So 75% moderate to severe would be 15.
Okay. That's how I'm justifying it. Now I'm writing out what I just told you. I'm writing down so whoever reads it can read it and they know where the hell that number came from. You never want to put a number down that they don't know how you got it.
Right.
So put those quantifying factors down. You took a percentage of this. It was whether it was mild, moderate to severe, severe. That's how you got to 25, 50, 75% of. Now they know how you got it they shouldn't even have to talk to you and they should know how you got it. Okay. Does that make sense?
Right. In this case, Doc, the ADLs was significantly more in the lower back.
Well, that's your judgment call then,
Okay.
whether to use the lower or higher number.
Okay. Great.
You know, if I'm going to use, when I'm always looking for with ADLs, it's not just the number. If I see a higher, more ADLs that are affected, I'm also looking for numbers to be 2s or 3s in the functional capacity index.
Right.
And in other words, it should correspond. Okay. If I do see a lot of ADLs, but they're only grade 1s, I don't care, even though I see a lot of ADLs, they're grade 1s. I'm not giving them the higher number. See, because I want to be able to say that for credibility. When I'm on the stand, I want to be able to say that for credibility. But this is why I didn't, because even though they had quite a few ADLs, they were graded on a scale of 0 to 3 and 1. So that's why we gave them the lower number instead of the higher number. See?
Right.
It's credibility. Okay. So that's what you would do in that case, is just take the lower number, and you don't have any range of motions to add on. Now you got
Correct.
you got two different regions of the spine. You got a 9 whole body in the neck and a 15 in the low back, right?
Yes.
Now you got to go to the combined chart in the back of the AMA guides. Remember, you don't add spine. You don't add separate spine. You combine them. You remember that?
Right.
Okay. So now you got to go to the combining chart in the back of the AMA guides. Start with the bigger number first on the left-hand side. Always go with the bigger number first. If you have 2, 3, or 4 impairments, that's how you do it. You start with the biggest to the second biggest, highest to lowest numbers is how you do the chart. So on the left-hand column, you'd go to 15. Then you'd come across to where it matches up with 9 at the bottom. See where it matches in the middle, and it'll probably be around 20. So if you added it,
23.
it would be 20, 30, 34 if you added it, or not 30, 24. So if you combine it, yeah, I would have thought it'd be a 22 or 23.
Nice.
You see how that works?
Yeah.
Does it sound like you might know what you're talking about?
Yeah. Yeah, it does.
Now, when you explain this to that attorney, do you see how you're going to blow him away?
Yes, I do.
You know what you're doing. It's what it sounds like. You're making everybody else look like idiots. And guess who gets the business? Not the idiots. Okay. All right. So any other major diagnostic categories? I'll tell you the only thing that I would have really paid a lot more attention to in this case. Definitely that dynarom. That dynarom would have been, because remember, it's 100% objective, and it's measuring abnormal muscular firing. And tell me there's not abnormal muscular firing with those pathological motor units.
Right.
You know there is. See, so that's you got to either get the machine, find somebody that has it so you can send somebody over there periodically until you get the machine.
Right.
For this case, this would be a very good diagnostic. It'd be a major diagnostic objective finding. Okay. Now, the other one is the blood test, inflammatory indicators. Okay. Now, why do I like those? Well, if you get positive C-reactive protein or sedimentation rate, how many people trust blood?
Everybody.
Blood's off the chart. Blood's off the chart. You get a positive inflammatory index along with everything else you found, blood's off the chart when it comes to trust. Those are the two that I really would have pushed for to really nail this thing. And he's just got a solid little case. This isn't a big case, but it is not a low ball offer. This is a solid little case. Okay. All right. Are we done with the diagnostics?
Yes, we are.
Okay. So you would come back. You would come back and you're going to remind him. Of course, you're going to put that in the narrative report. And then you're going to come back. And by the way, what are some key things that you need to include in the narrative report? One of them is why patients have pain or dysfunction and with some movements and not with others.
Even if the patient had, what do you mean by that, Doc? You mean as far as
Remember, there's a few major categories that you need to add in. One is the 3 phases of healing. So you need to include that document. Number 2 is the document that I send out that basically explains why people have pain with some ranges of motion or planes of movement, but not others. That's based on the science of the 3 phases of healing. That explains why people have, no pain when they're standing still or move a little bit, but then they have pain at the end of a plane of motion. That explains how that works. And then the other major category is degeneration, spinal degeneration. Okay, so.
And Doc, does that all fit into the addendums? Do you plug those into the addendums?
Yeah, those go into the addendums. I'll just take a piece out of it. I'll make a statement in the narrative, and then the whole full-blown explanation is in the addendum, is an addendum. Yeah. Those are separate addendums by themselves. 3 phases of healing, that's its own addendum. Spinal degeneration, that's its own addendum. That's its own category.
And Doc, since you're doing, in this case, I'm doing this financial driver case. Initially, when we talked a little while ago, you mentioned anything they have for their therapeutic protocol and their goals, you would put that in there. At what point would I add in the 3 phases of healing? Is it when I'm telling the story further down the line in the narrative report?
Yeah, you just follow the sequence, and the 3 phases of healing are under the prognosis and need for future care, because that's where it comes into play. This is why they're going to need future care, and it's going to get worse. And it has to do with the phases of degeneration. The impairment, when I right after I listed the impairment and the impairment indexes, that's when I'm going to talk about the pain with the 3 phases of healing, why they have pain in with some motion and not others. I'm directly tying it to the ADL or the impairment indexes.
Okay.
See how it makes sense?
Yeah.
That's where it naturally fits. So there's 3 categories that you have to make sure you add in there when you do the explanation. One is the 3 phases of healing. Number 2 is why they have pain or discomfort in some motions and not others. And then number 3 is what phase of spinal degeneration are they in? So let me show them to you right now. 5 stages of spinal degeneration shows what they are. The classification of articular cartilage based on arthroscopic findings, patients affected with osteoarthritis. Major factors that determine the spinal stages of degeneration. We listed all that: disc height, disc hydration, scoliosis, bone spurs, dynamic spinal structure, motor unit joint motion, cartilage degeneration. It's mainly cartilage degeneration and bone spurring are the main factors. And then there's a grade 0, 1, 2. Grade 0 is normal. So there's 4, 1, 2, 3, 4, normal. And we're talking about so there's the grading. And then here I listed normal, stage 1, and I listed common symptoms, common x-ray findings, common effects on range of motion. I listed all 3 ranges of motion: active, passive, and joint motion, and common effects on activities of daily living. So I went through each one. Stage 1, listed the common findings associated with each. Went to stage 2, listed the common findings associated with each. Stage 3 and stage 4 is this one right here. Of course, you should already include the 3 phases of healing. That's that one. But this one right here, this is why patients with a permanent injury have normal active range of motion, but pain and restrictions with activities of daily living and overpressure and joint motion. This explains why people have no pain or some pain or a lot of pain, and it's totally variable. So remember, you need to know that. Well, this is essentially copy and paste. I mean, we give them the impairment indexes. We tell them what motions, what ADLs had the pain, and then we cite this, and this just goes into the addendum. This explains all injuries through the science of the 3 phases of healing, major points of the 3 phases of healing. Each healthy joint has 3 ranges of motion. The 4 most common factors: patients heal wrong or suffer permanent injury to some degree, permanent problems associated with each phase of healing, when we heal wrong, and what it means to the patient. So I go through each one: inflammation phase, repair phase, and I'm just talking about the physiology of the 3 phases of healing, whether I'm talking about the neurology, whether it's increased nerve sensitivity, nerves getting trapped in the scar tissue, hyperinnervation, reinnervation of nerves, type 1 versus type 2 collagen, decreased elasticity with type 3 collagen, decreased strength with type 3 collagen. So that's what all this is based on. That's what all this talks about. That's why people have, can look normal, and they can maybe move 5 or 10, 20 degrees, but they can't bend over and pick up a laundry basket. That's why. So you have to be able to explain that. And then remember, the only difference between this and explaining constant versus irregular pain. So this is whether it's a fast twitch or slow twitch nerve fiber that's involved, chronic or acute nerve fiber. This mostly has to do with the acute. So if there's permanent damage to the chronic fiber, that's when people have pain without movement. So when I gave my impairment rating for the neck and low back, I told you how you reference that, and then reference the table you got it from. Do the combining, reference the combining chart, how you got the combined number. Then you're going to go to the impairment indexes, go ahead and list them. Then you're going to comment on them relative to the pain or restrictions they had with their activities of daily living. And then you'll include the attachment of why they had pain in some areas and not others, or why with some movements or some planes of motion but not others, and just include that attachment. Then when you go into the prognosis and need for future care, you're going to go ahead and list the 5 stages of degeneration, and then and what they're basically based on. It's basically the cartilage, bone spring, etc. It's all there. And then you're going to just say what stage you think they're in, what stage of spinal degeneration you think they're in, and that's why they're and this is how their condition is going to deteriorate and get worse over time. It's called the 5 stages of spinal degeneration, and then or the 4 stages, and then that's an addendum. The explanation is just an attached addendum. You're just going to make a quick reference to it relative to that patient. That's it. So those are the 3 big categories. So after you put all the major categories down, you want to make sure you include the active range of motion, or all the different categories. But when you're going into the explanation, obviously you'll have complicating factors in there, relative to that patient. But the big 3 ones are including the 3 phases of healing, that's what the care, and that's what MMI is based on. You got the impairments, AMA guide reference. You got the impairment indexes. With the impairment indexes, you're going to reference why do they have pain or restrictions, permanent pain or restrictions to some degree. There it is. It's the sheet that I just showed you. It's the 3 phases of healing and how they heal. That's why they have pain in some motions and not others, or more pain in some motions and not others. And then you just point out which particular motions they have. It's always typically going to be the plane of injury. That's typically where the problem's going to be. At the end of that plane of injury, that's where it all starts. And as a deterrent gets worse, it starts eating into the active range of motion more and more and more, and then bleeding over into the other planes of motion is what happens. And then and then when you go into the prognosis and need for future care, include the spinal degeneration chart and the tissues that are involved that I showed you there. And then just make a comment. What phase of spinal degeneration you think it is and why you think they're going to deteriorate and get worse. And there's the documents that show it. And you've got all the documents behind you supporting it. Make sense?
Makes a lot of sense, Doc. This is great.
Yeah. Now we're going to the heavy stuff now, okay?
Okay.
So you're going to show the attorney that, right?
Right.
Okay. He's pretty excited about now. Then you're going to point out what's the minimum 7 categories to create a high value injury award.
Right.
Mechanism of injury, subjective, hybrid, objective, MMI, impairment, prognosis, need for future care. You're going to point those out. And then you're going to show him what you have for each of those categories. In other words, you're going to show him the strength of the case. You got it?
Right.
And then the last thing you're going to do is going to go over to the 4 potential injury awards. Because that's what he's going to ask you now. How much you think I should ask? Then you're going to go over the 4 potential injury awards. You're going to go over the medicals and show him how the medicals is converted into money based on the science of the 3 phases of healing, the patient's biomarkers, and the frequency of care. That's how you total up the care for the inflammation repair remodel phase. That's real straightforward. That's how that's supported. The impairment. One method is to take the person's income from the time of injury until the time at MMI. That's a possible way of quantifying the impairment injury award. Pain and suffering is the same thing times a magnifier of 1 to 5. And that's totally subjective. How bad is this injury? Might be 1, 2, 3, and that's right out of workers' compensation guidelines. So it could be the amount of money from the time of the injury to MMI multiplied times a magnifier. And there's another way too. And other people, sometimes the attorneys will take just an indiscriminate number, like 50 cents a day. And they don't come up with a reason why they picked 50 cents, which I don't like. And then they'll multiply it times an actuarial scale. And that's how they'll get pain and suffering. So that's another way they do it, but I don't like it when it's indiscriminate like that. And then when you go to the prognosis and need for future care, it's straightforward. What was the therapy that was needed, the palliative therapy that was needed in MMI? Because remember, at this point, it's just palliative. You're dealing with symptoms, muscle spasms, restrictions, pain. So typically the patient needs chiropractic adjustment, some type of muscle work, whether it's muscle stim or massage. And I told you I typically give them, I also typically include a bottle of an anti-inflammatory supplement because it's there's no side effects from supplements like drugs, like ibuprofen and Motrin, and they're going to be taking this the rest of their life. They take ibuprofen and Motrin regularly the rest of their life. Now they got ulcers and all kinds of other problems. So that's typically the prescription I use.
look at the frequency at which the patient was getting care. Usually it's at least once every 2 weeks, but what was the frequency the patient was getting care when they ended an MMI, or what should they have been getting care? If you were being the expert witness, you now have to use your opinion. Then you take that times the cost per therapy, multiply it times the frequency, and then that gets multiplied times the actuarial age of the patient. How long does an actuarial scale give for the lifespan of that patient? You know how much this attorney's loving you right now?
A whole lot.
You could have taught that in law school. That could be a graduate class in law school. Yeah, you're the guy. You're the go-to guy right there. Compare that to what you didn't know prior to taking my course. Compare that to all the yahoos out there who aren't doing half of that and putting down cervical lumbar sprain strain and forcing attorneys to accept unfair, bad faith lowball offers. It's night and day difference.
Yes, it is.
And it'll make a night and day difference in your practice income and your quality of life.
And Doc, you told me to say something at the very end. You told me to say, are there any other doctors that you're working with doing this for you?
Yeah, that's a little nudge. That's all I do. But believe me, at this point in time, you're the man. But yeah, I do a little nudge and go, anybody else? And you have any other doctors doing anything? And I'll tell you the answer I always get. They say something like this. I can't even tell you how many times I've heard this. Not even close. I mean, that's a quote. I cannot tell you how many times I've heard that. Not even. How many of the other doctors are doing this type of documentation? Not even close. I can't tell you how many times I've heard that. Yeah, that's just a little reminder, I say at the end, just to remind them, kind of indirectly, I'm the guy. But just by going through the whole process, you're showing them you're the guy. So imagine all you've got to do is that whole cycle of presentation 3, 4, 5, or 6 times to make $1 million a year.
That's it.
Go ahead and take 5 or 6 or 7 attorneys. How many cases do they have? 2, 3, 4, or 5. Most of them only get 2 or 3, and then a larger percent will get 3, 4, or 5, or 6 or 7. And then a real small percent will get like more than 10. But you get 1 or 2 that get 4, 5, 6, or 7, and get 2, 3, or 4 or 5 that get 2 or 3. You just got what? 15 to 20 PI cases a month at a $4,000 case. 4 times 20, 2 times 4 is $80,000. There's your $1 million practice right there. From 7 presentations, 7 attorneys. I don't know anything else in the chiropractic profession where you can make that much money with that little bit of effort. It does take effort, but for the return is phenomenal. And I always say you compare the effort to like getting a DACBO or a DACBN, in chiropractic. That takes a hell of a lot more effort to learn to get that. And you don't make nowhere near. You may increase your income $10,000. That's it. If that. It's almost like a degree in name only. So you don't have to spend nowhere near the time. And you can increase your business $500,000, $1 million by taking that process and taking 7 attorneys through that process. And there you are. All right. I think we covered quite a bit today. Any questions?
Well, I think we covered quite a bit today. Any questions?
Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? Any questions? You understand how to present it to them and walk them through it?
Yes, sir, I do. I think you got me ready.
All right. Believe me, if you just did half of what I did, you'll knock his socks off.
I'm
All
looking
right. Do we need to
forward
talk
it.
about any? I'll send out those documents that I showed you. I'll email those out. Is there anything else we need to cover? And then look how much easier this is going to be. You know, the learning curve is always big on the first of anything, right?
Right.
Look how much easier this is going to be the second time around.
Yeah.
And then imagine how much easier it's going to be the third time around. The fourth time around, this is going to be a joke. Look at me. I wasn't even looking at any notes. See, fourth time you do this, you won't even be looking at notes. You'll just be going, you'll just be going boom, 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 boom. Okay.
And if I can say this, Doc, I would say that the first time is definitely the most challenging because you're not only trying to complete the narrative, but you're also we're learning as we go. And so you find yourself doing a little research so you can understand this category, doing a little more research so you can really understand this category. But as it all comes together, oh, by the time you finish this first narrative, you're like so far above and beyond where you were when you first started putting it together as far as what you know. It's just like you said, it's night and day, and it's
It is.
great.
Yeah, it is night and day. But that's why they call it the learning curve. Good news for you is there's not many people willing to learn it and do it. So you got a huge market out there. Huge market. All these attorneys are dealing with crap. And now they need people like you. And then patients need people like you to be able to go to court and be able to explain all this and put it together and to be able to tell the truth because they don't have somebody. Can you see how hard it is for attorneys now to find somebody, a doctor to go in court and testify?
Yeah, I do.
But man, once you know how to put all this together and explain it, that's why you become the expert witness, the go-to person. You get all the referrals. That's how it all works.